welcome to this session. I'm Baliga-Nicholson. I work at Sano. Sano is International Research Foundation based in Kraków. We develop solutions connected to computational medicine, AI, digital twins, and many more, connected also to robotics and virtual reality. So I'm leading this session. This session is for everybody who thinks that AI lives only in PowerPoint presentations. We will try to prove the point that it's actually, that's not true, that we are ready for solutions that have been developed by people who are not waiting for the system to change, but doing their job and changing the system along the way. So welcome to this session, and let's dive in. First will be Professor Kolasa presenting Koźmińskiego University in Warsaw. Kasia also works at University of Gdańsk, and she also is a senior advisor for business development at Sano Center for Computational Medicine, supporting strategic partnerships and innovation in data-driven healthcare solutions. Kasia is a leading expert in digital health, market access, and health technology assessment, with experience across the pharmaceutical and medtech and digital health sector. She has held leadership roles at AstraZeneca, GE Healthcare, Swedish Country Council of Kalmar, and many more. The title of her presentation is The Digital Transformation of the Healthcare System, Healthcare 5.0. Kasia, the floor is yours.
Thank you very much for the invitation. It's a great pleasure to be in Kraków. Actually, this is the second time I'm speaking in this spot. The previous one was about the HTA conference. Extremely pleased to be in Kraków, and thank you very much, Kasia, for very nice introduction. Indeed, I have more than 25 years of experience of working with health economics across commercial function as well as academic, with mostly international experience, but always I was linked academically in Poland. What I would like to give you a little bit of understanding is from my health economics perspective, how this digital transformation has changed the healthcare sector, and try to help you understand the future that lies in front of us, that is mainly driven by those innovative solutions that are not pharmaceuticals. Hence myself, I already moved to digital health, transitioned myself already before digital transformation 2018, when I set up within International Society of Pharmaconomics and Outcome Research, Special Interest Group Digital Health. And since then, my whole journey became related to digital transformation. That's why I wrote the book, which if you are interested, you are happy to see it in Empik or Amazon. But let me start from the very basic, because I understood that most of my academic career I taught about health economics completely wrong, and now the last 2 years I'm trying to change my wrongdoings, and this is because we still have the old perception that is not accommodated in the future, and the wrong perception is built on these two pillars that healthcare system were built upon, and this is paternalism and decision maker perspective. Paternalism is something that we in a daily life experience when we meet the doctor and simply get the advice from the doctor that we try to, as we used to say, comply with. Then we understood that compliance is maybe not nicely a perception of the role of the patient in this discussion, so we changed to adherence, so we adhere to the doctor advice. Now we understand that it's not good either, so we talk about the patient empowerment, human-centric healthcare. So paternalism was the idea that since there is a lack of knowledge on our side, we need to rely on somebody else. While doctor needs to rely on somebody else who holds the budget. So it's not on what we want, what the doctor believes is right for us, what the budget allows him to offer us. So that's the decision maker perspective. Obviously, was the decision maker in a Polish healthcare setting, National Health Fund, which is a single or multiple type of payers in different healthcare system. Those two pillars were built on that's what I'm saying about the wrongdoings, on the belief that there is information asymmetry. Doctor knows better, we don't know anything. The healthcare system needs to tailor this limited healthcare budget across unmet medical needs. And the wrongdoings, what I believe is has been present, which is not anymore, is this information asymmetry. Now, actually, thanks to data, I'm not saying that we know better than doctors, but at least we know what we want. And we know what others have published. We know what others have researched about. So we live in a different world that we used to have when healthcare system after Second World War were set up. Second thing is that this third party, which was believed that we need to have someone who understands unmet medical needs and helps prioritize who should have access. Then we got, of course, the outcome of this waiting list, the priority setting defined by the payers, defined by the reimbursement list, defined by the limitation of the healthcare financial system. So we focus on the treatment. We did not focus on prevention. We did not focus on prophylaxis with treatment, and we still do. Actually, all the reimbursement is about who should get what kind of treatments during the course of illness. But we don't talk about something that is very important: prophylaxis, prevention, primary as well as secondary. And the whole strategy about the decision-making became focused on the access to pharmaceuticals, access to medical devices. So again, about the treatment. The whole health economics, clinical trials are defined by the understanding how we can link this endpoint that we used to see in clinical trials with the health outcomes. So that's why the health economics helped to match these 2 points. So clinical endpoints with the real-time health outcomes. For example, cognitive declines versus patient and lack of independence after long time suffering from dementia. So those type of things where we try to purely focus in the era before digital transformation. We understood that focusing only on those treatment and how to allocate the budget, the doctors know better, we need to follow the advice of the doctor, brought us to the point where we have simply non-return. And the point of non-return, because we spend too much trying to focus on the problems after they have been diagnosed. Although Poland does not leading on the front of the countries that spend most of the healthcare, but still we see in a daily basis the discussion in the media that actually points to the direction. It's nothing wrong that we spend more, but we need to just change the words from spend to invest, and then we understand that the spending should give us some return on investment. And the return on investment is very needed because we suffer from the patient aging much faster than any other parts of the global world. Let us go to Asia, let us go to Middle East, and we see those differences very clearly. So within European Union, we are more prone to problems and more to failure of the healthcare system. Not to mention the problems with the obesity and consequences of it. And more importantly, lack of healthcare resources. So that's what we try to call paradigm shift always requires a disaster. So I think we are already now experiencing disaster. So this is the moment when we need to introduce the changes. That's why we are here in this room, because the change has to come from us, from those who deliver digital solutions. And this digital transformation will change hopefully the focus on the decision making from purely looking through the clinical trials, clinical endpoints to something more relevant, which is the how to save the money for the healthcare system, how to allocate the resources more into prevention prophylaxis before we discover the problems. When I sometimes a little bit tired of talking at the conference, I say tired, I want to arise more attention. I say that yes, AI will replace doctors, and I think that it's already happening. It's not only will; it's about it. It is true already today. There are a lot of algorithms that are more accurate than the patient with the patient diagnosis than the doctor eye, and because as simple as this, artificial intelligence is not getting tired, and as long as we have the right data with the right patient profile, we are able to use it for a better diagnosis than some doctors. In this particular example, there was collection of most world famous dermatologists, and their diagnoses were compared with AI tool based on CNN with melanoma detection. It's not new publication, it's actually from 2018. So we already see it happening. And then we already see the data being the decision maker is whenever we take the plane, this is actually driven not by the pilot, it's driven by the autopilot, means the data decide about the journey on our plane. So we are on that plane, but we are not on the data-driven decision-making in the healthcare. And the question is why we cannot do the same as the airface industry, use data more efficiently. And the problem is that in the healthcare, some rough estimates point even to 90% of the hospital data, for instance, being unused. We see that when we start to think about the digital solution and the data delivery tools, we can see a lot of successes that can translate to the speed. And I think the key element of the success for digital transformation is the time saving. There's no more important in today's healthcare than the time saving. The Command Center from Johns Hopkins and 2,000 more of similar kind shows that it is visible. We can save time, and by saving time, we can save patient lives by faster diagnosis, by the faster treatment, and that's why faster journey to recovery. First AI algorithm that has been reimbursed worldwide was actually in US, nomen omen, VisAI, company from Israel, that proved the point of faster diagnosis of faster triage for the stroke treatment, and they said that in this time window, which potentially most of you understand, 4 or 5 hours from the first symptoms to the stroke to the intervention to save the patient. So they saved 86 minutes by helping reading the CT scans and supporting the decision-making process. So time is the essence. And I think that a lot of examples show that we can save the time not on the patient journey, but also in the doctor office. Even LuxMed, with my recent discussion with them, try to build a strategy about the keyboard-free doctor room finally. So I think that's something that we can use the data to train the models. Even I'm supporting some startups from Ukraine. They are even there trying to think about how to use NLP to make sure that we prompt doctors with the nice wording. So ambient listening software is another dimension of this time-saving component. Time-saving is also data, and the data collection being faster. Nomen omen, Michael Fox, who suffers himself from Parkinson's diseases, make something that was very difficult for any pharmaceutical company to do, is to recruit a patient suffering from Parkinson in a time much shorter shorter than any clinical trials, with the numbers exceeding any clinical trials. So his foundation now, together with Roche, makes something that is remarkable, set up the new biomarkers for Parkinson's diseases. Thanks to the speed he managed to recruit the patient. How? Via social media. So we have a new platforms to operate and connect and build our understanding of the healthcare system. And that's something that is completely against what I said to you in the beginning about the paternalistic healthcare system. We go to the doctor office, doctor tells us what to do, we go home and follow the advice. This should not be the healthcare system of today. Healthcare system of today is us here in this room and understanding how our data can help us and others suffering from similar problems to introduce this time efficiency. And there are already pharma companies, not in Europe, but in US, that use that connectivity, so networking. So they literally give the patient not only the pill, but also the mobile application, and making sure that the adherence is built on the behavioral change of the patient. The more adherent the patient suffering from asthma in this case is, the higher success means the lower risk of relapse, and he gets a bonus in award point cards to be adherent. So the pharma sees it as opportunity to build a healthcare system based on patient centrism. So again, against the paternalistic way of thinking about the healthcare system. And those behavioral change are proven by other studies when we start to help patient recovery after the orthopedic surgeries with hip or knee replacement. So the telemonitoring inbuilt with the self-rehabilitation program at home reduced the risk of rehospitalization more than 3 times compared to those who use normal meeting with the physiotherapists in sometimes time intervals. So by being constantly monitored by the tools, we start to be more proactive, taking self-care initiative. And then those who use any kind of device of the tracking steps even, and myself, I do walk much more than I used to. The moment you start tracking your success, you are more prone to produce more success about it. And it turns out that those who use these tools to track the movement do 1,800 extra steps. So we do introduce the behavioral change. Behavioral change translates that now we can think about the prevention, primary and secondary, from different angles. So we can build the self-care component into the healthcare system and avoid dealing with the treatment, avoid dealing with the problems, but focus on how to postpone the problems, how to eliminate the healthcare problems. The problem is that we do not spend enough. And in the recent debate in Rzeczpospolita, I was preparing myself. I was shocked to see that we spend in Poland 22 euros on prevention, which is more than 15 times less than Germany does. So we don't focus on prevention, not even in our discussion. And that's a big pity, because already in 2017, there was a Nobel Prize that proves that behavioral change is possible. It's called nudge theory. And the Nobel Prize winner proved, behavioral science, that we can change the behavior if we give the right prompts to everyone. I hope that some of you has done it in your life, but I think that everyone knows that there is habit can be changed. And once they change, it's much more better compliance than to any other treatment, because it's us that does the change. So I think it's very important. And the example of it is in Singapore. That does not only what I gave you an example from this asthma treatment, but they literally give the mobile application to the patient suffering from obesity, suffering from the lack of physical activity. And those points the patient or individual collects are translated into financial bonuses. The problem is that we have in Poland, as you see, where our place is on digital literacy, it's very far. It's the worst score is only for Bulgaria and Romania. And so I think we have a lot room for improvement there. Let's look at the Netherlands that have zero problem on that note comparing to Poland. But I think that we need to do more effort on building the awareness and what prevention means, what self-care means. But that's something that is within our hand as long as we try to think that the healthcare system should refocus on the outcomes, not on the success of treatment, because sometimes it's not the same. So outcomes meaning that we should live longer and healthier, but also free from healthcare problems. So those outcome-based agreements already present for digital solution, for instance, in the US, like this Frispera, that is the lower propensity to panic attacks for patients suffering from mental problems, is translated to the bonus of the company. So company is not paid by the access to technology, it's paid by the delivery, what it delivers. And I think that's the future. It's easy, it's not. And the best case to show that it's not is the study done by Apple that recruited more than 400,000 individuals and tried to see whether this actually watch can detect atrial fibrillation on time. And they failed on meeting the primary endpoint. Not that it does not detect right, but that the patient was not collaborative. So they didn't return ECG patches to make sure that the result of the watch is validated. So they didn't reach the primary endpoint. Everything was fantastic plan, but one thing was missing: collaboration from the individuals being recruited into the study. So we need to build this outcome-based mindset into healthcare system, changing from the treatment to achieving what patient wants, what we can deliver, and help patient in their self-care journey. And we are not there within OECD countries, not to mention Poland. So that's a lot that we need to do. But the thing is that I think delivering the data as those who develop here in this room digital solution should think about the technology as data delivery system. And the moment we start looking what kind of data we can deliver about patient journey, behavioral change, outcomes we can achieve, then we start the perception of the healthcare system from this paternalism, what I said, to the self-care. We change from the treatment gain to the health gain. And then we see that actually we can save money, but not giving the access to new pharmaceutical only, but giving the access something that prevents us from being sick 10, 15 years from now. But that the whole healthcare system has to change, and it won't change from the current way we work with the pharmaceuticals, medical devices. It will change here from digital providers, because they will give us something that non-pharma, non-medical device has. Medical device maybe data. And I think let's focus on that, and I think we'll change the world we live in. Thank you very much for the attention.
Thank you very much, Kasia, for this enlightening talk. Are there any burning questions? Kasia will be available, of course, after this session, so I encourage you to talk to Kasia. She's also very good at explaining down-to-earth strategies, how hospitals could adapt and incorporate digital tools. So I think that it's worth talking to Kasia after the presentation. So we're moving to the next presentation. José Sousa, Sano Center for Computational Medicine, Computational Intelligence Team. José specializes in AI continuous learning, explainable machine learning, and decision support system for small and incomplete clinical data sets. He has led development of advanced tools such as Cactus and Sanda used in clinical and industrial settings, and supervises an international team of PhD and postdoctoral researchers. I think that his presentation and also his approach is very tuned with what Kasia was talking about, because the concept of citizen before patient, that kind of resonates also with the presentation Kasia had. So the title of the presentation, Beyond Compliance, How AI Continuous Learning Reveals the Real Hospital.
Okay, thank you, Kasia, for the nice presentation. So I promised Kasia that I'm not going to speak for 2 hours, and so I just have one slide. So, and I hope that I'm going to be, okay, this is the team, so the most important part. So this is the people that is doing the real work. So I'm just trying to get as much as I can from them. So that's my job. So it's very international. So we have lots of Polish people, American, Italian, that you are going to listen later. And now I'm building a new Portuguese team in Portugal. So, and we have been publishing a lot around fundamentals of research and machine learning. Catus is one of the things we just published. Machine learning and stability of features, because doctors, they would like to see every time a model gives them a decision, similar features. They don't want to see feature A and then suddenly feature X is going to pop up. So we have been publishing around a lot there. So as I'm not very good on designing, infographics, I use the tools that are available. Okay, so I asked these large language models, draw me a picture of a hospital as a complex adaptive system. Okay, and those boxes there are the things that you got it wrong. Okay, so they got the things wrong. So I had to go and correct it and say, and then because I didn't have much time, I just put those boxes there to make things a story. Okay, so that's what I'm going to talk about and how technology can help you to understand. So we live in an era where we think we know, but we really don't know. So the thing is, the machines that we are building, they live in a story of projections. They live in a reality that is projected by our data, okay? So if you are familiar with the Plato dialogue of the cave, you see that, someone is sitting on a cave and then the images were passing by. And this is the data-driven thing. You feed that into a machine, and the machine builds a story around the data. But our world is more and more rich than that. So our world is an entangled world. So we live entangled in technology, and the hospitals are that case. So work as imagined, is that you have those very nice connections, between users, software, and infrastructure. But how the work is really done is completely different. Okay, so we rely on a lot of informal interactions, informal entanglements that are really drivers of the organization. And if you go and look into how difficult it is to put AI into hospitals, it's because we build AI for organizations that don't exist. Okay, so when you try to put a tool in an environment that you imagine that, okay, that's the connection that you have, and in reality they are not, you are damaged by that environment. So what we are trying to propose is we can use AI to understand that. So we can deploy tools that can allow us to model those clouds over there. And then, okay, we understand how the organization really flows. And then we'll develop and we'll deploy technology that is going to really change how the hospital works. So this is a couple of examples that we have been working on. For example, not very much hospitals have very well documented business process models. Okay, how the pipeline on the hospital is organized. They are mostly focused on the outcome and how they are going to report to the government, to the ICD-10s that are more profitable. That's what they want in the end, and they build all the story around that. But that is a digital path. Those are digital elements that you can capture on the hospital infrastructure that gives you a real picture on how things are interacting. So, and you can see, how the processes are connected, who activated the process, how everything is digitally mapped. Okay, and that is the operational. So this on this side is a Portuguese case on ERP project, okay, where you were able to map the changes in people. So people moving from one department to the other, and you could see, how that was logged into the system. So the data is there. It's very hard, of course, because if you present any of this to any machine learning person, they'll say, oh yeah, I cannot work with that data, it's too noisy, lots of missing data. So my team has been working very hard on that, trying to make that useful for being supportive of the decision-making process. So I'm just putting here a very simple example of technology that is in the market. Splunk was acquired by Cisco, if I'm not mistaken. So people that is connected with technology knows what I'm talking about. So this is what we call a sniffer. You put this sniffer on your network and smells the data flowing. So it's quite very easy to implement, gives you that type of output over there. Okay, so IPs, the addresses of it. And then you can use that data to train knowledge and to build understanding of the organization. And you build these type of things. That's what we do. So you build models that tell you, oh, yeah, okay, so on the process we found that we look into, there is this huge amount of connectivity. And you know what we discovered that we discovered, for example, that the reimbursement was being delayed because the company was always asking for you to upload the digital invoice that you got from them. And you buy something and you forget where you put the digital invoice. So if you don't upload it, they don't reimburse you. So there are lots of mechanisms that you are able to detect that the things are not working properly. You go to the middle side, and you see those two networks changing because the organization changed. So people moved from one side to the other. And you can use that information to build models that are going to allow you to understand where you should be putting your next big invention. And then on the right side, you have a portal architecture that nowadays are everywhere. So every institution has its own portal where you make login and you put your information, and then you can model it. So you can model the interactions between the elements in the organization, and you can understand how the information flows. With that, you can do really co-creation. So you can bring those elements here, so you can bring the connection that you imagine is there with the real virtual organization that is built through the interaction, okay? So then you can move to something like this. So you can have a profiling network or a profiling model that tells you, yeah, I can measure those things, I can integrate them, and then I can build these virtual organizational models for which I can take decisions and build technology. So that's the learning hospital that we aim needs to be in place if you want to make AI successful. Okay, so you need to understand what is the reality of your deployment, because this aim that we would like to change and move everything to a better place to allow people to do prevention, to use that data cannot be done unless you understand where that data is feeding into the system. So I think I'm perfectly on time. So I just have the last slide. And again, going back to the beginning, I asked the large language model, give me a model of how this interaction with AI and the existing system will work. And that's what you got. It said, oh, you should develop an AI continuous learning cycle that looks like that. And I said, okay, yeah, that's amazing. We are mostly doing that. That's good. So we are capable of generating insights. We are capable of having impact because we are addressing a fundamental problem is that we are trying to understand how things are done and how things are happening. So yeah, so that's my email over there. So my team or the teams that I'm managing. And I'm more than happy to discuss and talk about any ideas that you have. Okay, I'll be here the remaining of the day, I think. I don't know if there is time for questions. Yes, well, so I was trying to do my best to be as fast as I can, So if you have any questions.
Yeah, absolutely. Well done. I lost the bet. So yes, you are on time. Yes, yeah. Well done. Anyway, yes. I think that you are addressing really important point that understanding the system that we're trying to plug in the solutions is very important, and we're delivering the value to that system, not interfering and adding yet another tool to learn. Any questions for, there is one from Kazimierz Murzyn.
Thank you. Are you saying that we may having access to the hospital data, complete hospital data, but not this from, not exactly from the ERP system, but from all data sources in the hospital, like emails,
yeah.
like social media links, etc. We may find some kind of structure and incrementally improve step by step with each iteration.
Yeah,
that's the idea.
That's the idea. So what you discover, so it's this is, by the way, this was my PhD thesis. So it's part of my PhD thesis. So like a couple some years ago. Yeah. I don't like to talk about my PhD because I'm getting older since I got my PhD, so it doesn't work very well. So yeah, so this is the things that you get. Okay, so these are the things that you get. So you get connectivity, across all the things. So these are the examples but we can use emails, for example, to implement. One of the things that we found there, for example, on the operational data, and it was a very big telecommunications company, was that, they had the process going in a wrong way because they wanted them to be wrong or take longer to provide reimbursement. So with this information, you can build the reality of your organization. So you build how things are done. And from there, you can really go into, define the pipeline, changing the pipeline, and deploying the technology where it's going to make a difference. Because 95% of the AI implementations at the moment are failing. So even the big names are struggling on implement, because one thing is what is an organization that is on paper, the other thing is how the work is done. Okay, and you have to understand this. And so the thing is that we are capable of delivering this. The technology is there, so you can have log configurations, so everything is there. Okay, the difficulty, and what Sano does very well, we are capable to transform this, and that's how I would say our, selling point. If you want to sell this, we are capable of taking this to this. This is the driving motor. So you cannot do anything with this. So people are doing for, threat analysis and so on. But when it becomes this, you can relate a lot of.
Okay, thank you very much. Just to add one point to this, we're working with the hospital in North Poland, long journeys on the train. And I remember when we were discussing this, because we had to see who is using the software that is in the hospital, and it occurred that those are the nurses who fill the data to electronic health records, and the doctors are not doing that. So actually we had to be very friendly with the nurses if we wanted data. Yeah, thank you, Jose. Thank you very much for that. Okay, excellent. Next. Arkadiusz Klej, speech flow, designer of edtech solutions at the intersection of design, business, and public policy. On a daily basis, Arek designs educational tools and games aimed at speech therapists. As an expert and workshop facilitator, he has worked for public entities, private and public universities, and large private sector entities, banks. I've got here one name of one big bank here, but I'm not going to say which one. Anyway, the title of the presentation, how can we help speech therapy patients by leveraging generative AI technology? The floor is yours.
Thanks a lot, everyone. To be honest, I'm very happy with the two previous presentations because I feel like we are trying to achieve exactly what was described. As a speech flow, for a short introduction, we are working on the technologies related to allowing patients to have very, very personalized approach without spending the time of speech therapists. I will check, is it working? Yeah. So many of you might ask, is a speech therapy really a healthcare? That's actually a question that I quite often hear, and I can give you one funny data. You might know NIK, one of core control institution in Poland. So there are reports reporting that 1/3 of the doctor's time is actually related to the administration burden and the tasks that are correlated to those. So for a kid in Warsaw that will have to wait 3 months for the first consultation with the speech therapists, it is like waste of the time because, as you might expect, almost all of them won't wait if they will have money to go for a private sector. Unfortunately, most of our society won't have the resources necessary for that. So the first thing that I want to share with you is the fact that actually by automating we can liberate the resources and therefore help patients that are currently incapable of having the necessary treatment on time. That's one thing. The second thing is very correlated to the data itself and the medical error potential, because as you probably all know, because most of us probably provide medical solutions and developing those. While the system is working, we can at least use logs in order to check where were the errors provided, incorporated, or what was the missing input or the wrong input. The same NIC report suggested that at least 70% of doctors suggest that in previous 3 months they might have some medical errors. So that's current situation regarding the speech therapy. Why speech therapy is important? It is practically 4 things that are the most needed for you to be a member of the society. It is reading, writing, understanding, and speaking, the communication. Without those, all the people that could be with us aren't actually able to understand, cooperate, integrate. Therefore, the society actually cannot develop. How the speech therapy is changing is very visible after the speech pandemic, after the COVID pandemic, when the demand for the speech therapy, for example, for preborns and the youngest kid, increased by 90%. So the change is dramatic. In 1980s, less than 20% of kids needed in the kindergarten needed a speech therapy assistance. How do you think, how much is it currently, 2025, after the pandemic? How many kids, while they are going to the kindergarten, actually needs assistance of a speech therapy? Can you give me a guess? 60, okay. I can hear more. 80. Oh, we are getting closer, yeah. All of them might be correct answer depending on the size of the city, because it is between 90% and 100 actually. In smaller cities in Poland, I want you to be aware of that, because it's not the case in Kraków, but in the rural areas, in the kindergarten, none of the kids is speaking. Of course, fluently according to their development age and so on. So in 40 years, the situation changed dramatically due to this digitalization, various circumstances. Pandemic was like the killer of it. And now we are here. 40% of speech therapists in Europe regularly report burnout symptoms. Therefore, if any of your friend's kid is going for a speech therapy, it is actually a toss of a coin. Is he or she is going for a speech therapist for the therapy, or for the therapist that would love to kick the kid out of the office, actually? And I'm actually not blaming them a lot if I'm wondering that 1/3 of their time is documentation. So the reality is there's too much paperwork, as all of us see this. I think that there's a lot of things that we can change. We are in the speech flow doing this by providing electronic health record system regarding for the speech therapy and the automation of it. And the thing that we are actually working on that is very correlated with the things that were described before is the fact that we are using the data that we are collecting in order to use set of solutions regarding to generative AI in order to develop very personalized games. So you can think that we are making cards that are related for the patient's needs. For, let's say it is Mr. Zdzisław after a stroke, he's 70, and for him we need to make a tool, a therapeutic aid that will be engaging not only for him, but also for his environment, because lack of this interconnection between patients and the care is one of the things that even if we are going into the therapy, the work on a session, 30-40-minute session, will never be enough without support of the family, support of the surrounding stakeholders, let's name them roughly. So the idea is that we need to provide such people with tools that are very personalized And normally, some speech therapists do this because it is very effective, but it is very time-consuming. So doing this by hand takes tremendous amounts of time, like 2 hours per single therapeutic aid. With SpeechFlow, we're cutting this time from around 2 hours to 15 seconds if we strike with everything correctly, or up to a minute if the speech therapist needs to change something. And it is very, very simple, comparing to, for example, second-class medical devices and so on. However, the problem is still not in the speech therapy aids, but in the model, the economic model, as it was mentioned in the first presentation. Because as long as speech therapists are paid by the time that they are interacting with the patient, some of them, sorry to say that, have some economic benefits by not taking great care in the quality of their services. So for very simple information, of course, we can personalize. We might ask whose responsibility it should be that will provide the quality of the care, not the quantity, as it was mentioned. So we came up with something that is called, not exactly we, but we are using AIDS design framework. So it is the general idea that every therapeutic tool can be personalized on 3 core levels. First, the therapeutic needs. Secondly, the patient's problems, the technical restrictions that are necessary. On the third level, on the level of the preferences. And by taking this approach and using patients seeing patient as a human, we are capable of letting him and his environment do most of the work that is actually necessary. And actually, the technology behind it is not actually AI-driven, it's layers of technologies related to the generative AI, to more static approach. So I should say something positive about us. So yes, we are already piloting with EIT Health, so I won't say this a lot. We are training speech therapists, because I think that the second thing that is even more important is the fact that in current speech therapist office, for example, in Łuszczówka, there's a place called Łuszczówka, actually close to the Ukrainian border. I've been there a few times to provide training for the speech therapists, actually. And their problem there is to have an internet connection. And for them, like, the new thing of 2025 was a common mail to share the data of the patients. And I would say that this is really the state of the Polish medical scene that I know. Of course, that we have great hospitals that are doing R&D. I'm very happy about that. I think that we need more and more of those. But actually, I think that the real case is the fact that most of those stakeholders do not even use the computer, not talking about the clouds. And that's the step that we are in, that we are thinking that we are capable of speaking, writing, talking, listening. Here in Warsaw, in Kraków, in Budapest, in Barcelona, I'm very happy that we are doing this. But it is like 15% of our population, depending on how you count it. But still there is more than 80% that needs much basic need, that have much basic needs. And by providing automatization in cooperation with training, with very simple tools that are accessible, we are capable of saving both time and money of the NFZ, of our public healthcare system. So that will be it. Of course, there should be some more arguments regarding dignity, and I think that there is one very simple. I hope that one day, when I will be around 80 years old, I will be guaranteed, it will be a guarantee for me that I will have support necessary not only to exist, but to still be capable of being a useful member of the society. And the word useful is for core for me, because we are not talking only about the fact how long we will live, but even more importantly, how long we can live together. And that will be all for me. I'm Arkadiusz Kolej from SpeechFlow. Thanks a lot.
Thank you, Arkadiusz. Well done. Also, I know that you're going through the patent journey, so that's why you can't talk in details about technology, but well done. Okay, the next is Konrad Komnata Mentalio. Konrad is there, entrepreneur, inventor, and software developer with over 10 years of experience in building digital health solutions and applying artificial intelligence in innovative projects. Co-creator of Mentalio, an AI-based psychiatric diagnostic tool for children and adolescents. Co-founder and CEO of Nivalit, author of 16 patent applications in the field of AI and data management, and author of multiple scientific publications in computer science. Konrad.
Thank you, Kasia, for a warm introduction. A lot of data you mentioned. I would like to talk to you about Mentalio. And this is a brilliant setup of presentations because it's quite a continuation. And I'm going to mention, especially to what Jose mentioned. But first, I would like to talk to you about the problem, what we are fighting against, and what is the main challenge. Mental health. I'm not going to talk about all the cliches because you are reading social medias, you all read the newspapers, but sticking to the data, almost half of young people were or will be considering a suicide attempt. 4 million Poles are suffering from the depression. Not mentioning the pandemic, the data after the pandemic is terrible, but this is the challenge we are facing right now. And with this challenge, there is not enough specialists to support adults. But from my perspective, the most important thing, we are facing the situation when there's not enough specialists to support those who need the help the most, young people. We should have at least 3 times more child and adolescent psychiatrists to cover the needs we have. And what are the needs? What are the data? The terrifying data that triggered us to start the project is the suicide data. Official data from the police shows that the number of suicide attempts and suicides successful. It's hard to use the word successful suicides in this context, but the number is increasing. And what we know from the psychiatrists we are working together, most of the suicide attempts stay at home. Are not registered, are not in official reports. And this problem is not only in Poland. Let's say the whole, developed society has this issue that those numbers are increasing. And there are multiple attempts to solve this issue. There's a huge reform of mental health care in Poland, in Europe, in UK, especially right now. What's happening in UK is very rapid development of mental health care improvement. But right now we are in Poland, on 3 levels of mental health care support. Right now, the psychiatrists are on the top level because there is not enough of them. For the whole Poland, there's 568 child psychiatrists. Just imagine, for the whole country, almost 600 of psychiatrists, and the problem is increasing. So we had to do something. Knowing this issue and having the technology, we together with specialists from various hospitals, there's almost 100 of specialists working with our technical team. We've created a Mentalio, which is a medical device helping the diagnostics and triaging of child and adolescents having issues with their mental health. Not only to support the diagnostics, not only to say what's happening with the patient, but what is most important to fix this pyramid is suggestion what should be done with the patient. So it's not only a diagnosis of supporting. It's very important, according to what you said in your presentation. We are supporting. It's not autonomous system because the law doesn't allow autonomous decisions. We are supporting not only what's happening with the patient, but also what should be done with the patient to improve their mental state. We are gathering data from the patient, from the caregivers, from the psychologists, psychotherapists, and from the doctors working with the patient. And mentioning what Jose said, there's always somebody missing. The full data record is from the patient, from the one parent, second parent, from the therapist, from the doctor, but there's always somebody missing. So our solution had to be working with missing data by design, because we never have complete image of what's happening inside the patient's mind. And right now we have created this tool. This tool is right now under the clinical trial. We are supporting the doctors with predictions. We are supporting the doctors with the image of a patient, because there was nothing like a ultrasonography or MRI in psychiatry. There are two ways to gather the data: talk to the patient and fill standardized forms. Ton of the papers, hundreds or even thousands of questions. Patients, to get the whole image of a patient, we would exhaust the patient. And we are talking about the very fragile patients, very vulnerable patients. So we cannot overwhelm them with a huge amount of tests. And to make you all sure, because we are dealing with very delicate matter, this is all done with the state of the art. We are following clinical procedure, we are following clinical validation, supported by medical research agency. We are working with 5 hospitals. We started here in Kraków, but right now we are working with hospitals in Morawica, in Poznań, Łódź, and Gdańsk. So not to brag about it, but this is the data. I'm proud of it, but also terrified, because right now there's 124 medical specialists working with us right now in the middle of clinical trial. But remember the number I told you previously. In the whole Poland, we have almost 600 of doctors. So right now, in only those 5 hospitals, 1/6 of them is already working with us. The situation is terrible. And what you've said, there's a huge problem in smaller cities, in villages. We cannot multiply psychiatrists to cover the whole region of Poland, mentioning even the Europe. So if we can do something with technology, right now, I feel like it's our duty to do it. So why we are doing it? Mentioning also your presentation, data. Data is the fuel. We are gathering the data about the patients to lower the diagnosis time, but hospitals are prone to buy it because they see the savings, because we are saving the doctor's time. So the administration of hospital, they just see real savings. So this is the, let's say, administrative and business fuel for the project. But this is our goal. Our mission is to help them, to save them. Thank you very much.
Thank you very much, Konrad. We're moving from very important topic, from brain, from mind to the heart. Rafał Samborski, Cardiomatics, entrepreneur with a strong technical and academic background, CEO of Cardiomatics, a leading AI company for cardiac professionals. Rafał is the author and co-author of peer-reviewed research articles in the field of digital signal processing. He has PhD and Masters in electronics from the AGH University of Science and Technology in Kraków. The title of his presentation, Scaling ECG AI Across Europe, How Cardiomatics Grew from 100 to 500 Clinics in under 2 years. The floor is yours.
Thanks. Thanks for the nice introduction. Welcome, everyone. So, as you may know, cardiovascular diseases are the main reason of death globally. So we are not solving all the problems with cardiovascular diseases, but we are solving a particular problem, which is early diagnosis. So one of the most common procedures in diagnosis of cardiac diseases is ECG examination. This is pretty common. Most of the cardiac patients goes through that procedure. The two main problems with ECG interpretation are that it is very inaccurate. The data shows that on average, physicians interpreting ECG achieve 54% accuracy, which is pretty low. So if you ask 3 random doctors about particular ECG strip, they will give probably 3 different opinions. And second important problem is that ECG examination, especially for long-term recordings, is very time-consuming. So from the very beginning, we thought we need to somehow solve those 2 problems. And I will try to explain how we made it happen from the product perspective. But even more importantly, how it helped us to grow our customer base up to 500 clinics currently using Cardiomatics across Europe. So in the core of the product, there is an AI algorithm that is our proprietary technology. It was built fully internally by our team. It was trained on more than 300,000 ECG recordings coming from multiple centers across Europe. And what we are the most proud of is that there are currently several clinical studies presenting the high accuracy of our algorithm. One of them is here on the slide. So we were comparing our output with output coming from trained electrophysiologists, and we achieved close to 100% correlation between our output and output coming from the trained experts. This was published last year in one of most respected cardiac journals. So behind that data, there is aspect of trust. So I believe that the most important or fundamental reason why we were able to achieve the current commercial footprint is that we were able to present the reliable peer-reviewed data as an evidence for our technology. So I would say certainly the most important and the fundamental aspect was trust. The second one is the economics. So I think we would not be able to achieve the certain stage without clear evidence that our solution really saves time. So currently we are able to present it on real-world data. And we have real cases presenting that after deploying our technology within a clinical environment, we are able to cut the costs or time of analysis by more than 80%. So just to explain to you what it means from the patient perspective, average waiting time for Holter to be interpreted across Europe is 6 to 8 weeks, depends on the country. At customers that deployed Cardiomatics, this time goes close to 0. So patients in the clinics that use Cardiomatics, they have their results ready either the same day or the worst case, if the result needs to be confirmed by the doctor, is the very next day. So the very important bottleneck is currently unblocked. So we've got trust, we've got economics, but the third important aspect is technology, or I would say compatibility with existing clinical environment. So currently Cardiomatics is the most hardware agnostic solution available on the market. So we are compatible with more than 50 different ECG recordings, which makes the whole product available for almost any clinic without changing the equipment. So it is very important reason of our current trajectory that we are able to sell the product without need of changing the equipment, without the need of training nurses or staff to use another recorders. So to summarize, the three, in my opinion, the most important aspects of deploying our technology across Europe are trust, clear economical benefit, and easy deployment and hardware integration. So where we are now, as I mentioned, we are in 500 clinics. That was pretty crazy 2 years because we made it happen. Most of that was deployed across during last 2 years, and we are not stopping here. So the goal for the next months or next year is to at least double that number. So we would like to have 1,000 clinics, facilities using Cardiomatics by the end of the next year. And the counter of recordings or patients impacted currently is on 300,000. This is all commercial, and all those patients benefited from our solution. And hopefully that the next year will be even bigger and quicker. So thanks for that. I'm here until end of the day, so happy to discuss more after the session. Thank you, everyone.
Thank you very much, Rafał. I think that with this success, the scale is something that comes to mind and how you achieved that in such a short time. So I'm sure that the conversations will be about the business models and the frameworks that you're using so effectively. Moving on, Jacek Mikosz, co-founder and a chief product officer at FindAir. He specializes in designing and developing IoT medical devices, automated monitoring systems, and patient-facing digital health solutions. Over the past years, he has led the development and launch of multiple award-winning medical devices used in both clinical therapy, clinical environments, and everyday practice care. His work focuses on translating real-world therapy behaviors into meaningful data, integrating smart devices with clinical workflows, and improving treatment and remote care outcomes. Title of the presentation, Turning Every Dose into Data, Designing the Future of Smart Medication. Jacek, the floor is yours if you prefer this one.
Thank you very much for that introduction. I'm Jacek Mikosz, co-founder and chief product officer at FindAir. We are a Kraków-based company that since 2019 is developing solutions for remote patient monitoring, mostly in the topic of respiratory diseases, focusing on medication intake. We are a combination of designer, engineers, medical experts, and data analytics people who are working to create a complete solution and to provide real-time medication monitoring data. When we think about chronic conditions such as asthma, COPD, diabetes, or cardiovascular, the one key factor that is common is that the whole treatment plan is based on medication intake. The medication intake, if it's a tool that transforms diagnosis into care. It is a foundational layer that creates a treatment plans for all those therapies. Yet we made enormous progress in digital health, but medication still remains invisible. We don't know how much and when the patient took their medication, and we have no way to check that. Chronic patients take even 6 doses a day, which creates a huge amount of data for every patient, every month, every year. And every missed dose that we do not capture is a missed data point and missed opportunity to understand the patient outcomes better. Medication fails because of two main reasons. One is simply biological. The given medication doesn't work for a given patient in a given context. And the second one is behavioral. The medication could work, but just isn't taken or isn't taken correctly. And we at Finder are treating every medication package as a data source. We believe if we're going to equip patients with the devices that's going to integrate into their homes, into their lives, that's going to seamlessly gather data without patient effort, we are able to gather 240 data points per patient per month and share that with any party involved. Our system relies on 3 pillars. We focus on capturing and connecting the device. Later, that data is sent to the patient app, to the patient interface, where he can enrich that data and view it, analyze it, and of course, it can be shared with the doctor and clinician. The clinician can analyze data and intervene if needed. We focus on 2 verticals currently. One is smart add-ons that are ready for deployment today. We are selling them to remote patient monitoring platforms and clinical trials to gather data about existing drug delivery devices and how they are used in the home environment. And the second one is more advanced. It is not only measures medication intake, but also measures how the medication is taken. It understands the inhalation flow of the patients, it understands its errors, and try to correct the patient when the correction is needed. It is currently sold by us to the hospital. It is especially useful for people who are entering the treatment and learning how to use the devices. But it was developed as a fully smart drug delivery device that is compliant with all pharmacopoeia requirements, and it's ready to be deployed with pharmaceutical APIs. We have proven our work and our devices in numerous of partnerships with leading institutions all around the world. But would be great to find also partners here in Kraków. We are very excited that this ecosystem is growing and events like that are happening here. So if you have any idea, any new project where the quantified medication could be useful for you, we are open to talk. I'm here for the rest of the day, and we can manage to find some ideas and solutions together. Please remember, if something cannot be measured, it cannot be improved. And that's our principle in Finder, that we want to provide tools to measure all those data that are currently invisible. Thank you very much. Thank you for your attention. Thank you, Tim.
Thank you, Jacek, and thank you for also reminding that we are here to connect people. So this is a call for collaboration and also maybe working together towards new projects. So thank you for mentioning that. And we're moving towards the next presenter, Bernard Gołko. Bernard Gołko is the CEO and a co-founder of QVT, a Polish neurotechnology company developing dual-use neuromodulation solutions for civilian healthcare and military rehabilitation. His work focuses on applying non-invasive brain simulation to accelerate recovery after stroke, traumatic brain injury, and post-traumatic stress disorder, and to enhance cognitive resilience in high-stress operational environments. Bernard, the floor is yours.
Actually, this is the first day with you guys and with the whole cluster, so thank you very much for having us here. Let's get back to the brain for another 10 minutes. where I'm coming from, basically, we are also relying on the data because this is the key for us to have possibility to implement anything to the doctors, anything to the investors as well, because we can prove what we are doing on daily basis nowadays. We started our journey with different hospitals worldwide, helping to treat patients post-stroke with dementia or with other neurological disorders. However, last year proved us that we are also double-use technology. So where we are at the moment, basically, we are joining a Polish military force, not only for the reasons of therapy, but also for the neurocognitive boost as well, so neuro enhancement reasons that I will explain in a second. Second thing is that we are working naturally in the world of civilians as well, so please don't get me wrong, this is not only about military. However, to have something new, something fresh for you as well, that we can share, this one will be about military mostly. We see what is happening close to our border. We see what are the threats worldwide nowadays. We see how many soldiers are being treated because of the depression, because of the PTSD. Do you know, guys, what is the percentage of soldiers that touched the gun, that tried a military action, that have depression? More or less, percentage-wise. 52% when it comes to the United States, but it's even higher when it comes to the heavy burden that is taken on the ground close to our borders. We see that there is a high psychology and cognitive load also because some young soldiers, they are under huge stress because of the number of the data, the inputs that they need to digest, they need to process to become a soldier. So they are constantly tired, they do not sleep much, they need to find themselves in totally different environment and to be ready in even a couple of weeks when it comes to the Ukrainian battleground. We see that most of the soldiers also, they have, once they are back to the society, they suffer because of the PTSD. However, what we discovered, this is very sad actually for us, that especially in Central Europe, not too many officials or not too many experts, they are keen on focusing on PTSD, because PTSD usually after the soldier is out of the army, so not that much needed. It's a pity, but this is what we observe on a daily basis. We see that there is a lack of effective brain recovery tools, and that actually the cost of the rehabilitation is growing rapidly. When it comes to the post-stroke, for example, in the United States, this is between $140,000 up to $200,000. And it's not only about the cost of the therapy or reaching to the specialists, not too many of them, 50 years old plus, but this is about the logistics. This is about the necessity after brain injury, after problem, post-stroke, to have a person, a companion that will take me every single day in the forthcoming 6 months or sometimes years for the sake of the treatment. We provide a quite unique solution. We are the only provider from the CE region of the transcranial electric stimulation, where we focused our first steps on neuromodulation, on transcranial electric stimulation. You can see the device in the other room, so more than welcome to discuss what exactly we are doing. We are providing small current to the brain to boost the neuroplasticity, to give the possibility for the brain to act like a little bit younger, to create faster the connections between the brain cells, so to learn once again the things that we forgot because of, for example, of the stroke, or to provide the micromodulation for people with depression or PTSD. We combine this with immersive VR therapies. Why? There are lots of solutions right now in VR because we need to bring the therapy home, because this is not enough to provide the better therapy at the hospital because of the logistics problems, because of the necessity to travel. So there needs to be something that is proven, that works under the regime of mathematics, basically, that is used by the patient under constant supervision of the extra system that gives the feed, gives the data to the doctor. So at the end of the day, what we are going to present in 5 months, it will be globally scalable supported platform. We already work with number of hospitals worldwide. This is something that I will tell in a second, but we already see that the first results are very promising. We are already medical grade hardware provider. So we are already in more than 40 countries. We work with VR stimulation to make sure that this is not only at home, but also what virtual reality gives you possibility to put the patient in the right context. It means that the patient is no longer trying to get back to the normal daily activities by the small desk in the hospital, where the surrounding tells him this is not home. This is not where you should be. This is about putting the patient in the right context, in the virtual bank branch, in the shop, or at home. So again, at the end, we have a full platform that will be possible to use at home or for the soldiers in the trenches. This is something that we are testing right now. We are a worldwide organization, so last 3-4 years, we managed to provide our services and our solutions to basically every single medical university in Japan, most of the medical universities in United Kingdom, but we are also in exotic countries like Japan, Hong Kong, like Hong Kong, India, or Argentina. We are working with Harvard Medical School. All of the research for transcranial electric stimulation are done on our devices. This is amazing because we are from small country, from Poland, where we managed to show that we can work with the big ones. Shear Reliability Lab, this is something that I'm disclosing right now. We didn't talk about too much in the social media, but Shear Reliability Lab is the 30 consecutive years the best neurological research center in the United States. This is where we are doing our FDA certification. We have a possibility to treat several different mental or brain problems. And we are the only company from Europe that has possibility to use all of those, all this technology for children as well, under, again, strong supervision of doctors. When it comes to the military, number three is the brain injury. Number 2 is chronic pain, but number 1 is depression. This is what we observe right now in terms of huge epidemic when it comes to the not only Ukrainian military, but the same starts happening in Poland. The results, the mathematics. So basically when it comes to the therapy, how this microcurrent works, this is non-invasive. So this can be used for children, but still this is powerful. Up to 35% reduction in PTSD and depression symptoms. So basically you don't need to get the pills to get back to the normal function, especially at the beginning of the depression. 20% decrease in stress levels, 25% reduction in chronic pain. But we also, what we also observe is the shorter neurological rehabilitation time. So actually, we boost the process of getting back to normal. What is even more not discussed widely is the military purposes. We see that increase of the concentration span is up to 30%. And why I mentioned young soldiers, they should be without a problem, but they are under huge cognitive stress. The number of repetitions that they need to do to learn something like assemble, disassemble a gun, this is thousands of repetitions. It is proven by US military, IMV, NATO Center of Excellence, that it can be cut by 40%, so speed up the process of the preparation of the young soldier. Greater resilience of fatigue and skill retention, rising by more than 60%. At the end of the day, this is cheaper and faster, and yet this pays off after, from the perspective of the normal hospital, it pays off after a couple of weeks. We are riding unfortunate wave because we see that the number of problems are growing rapidly. In Poland, 5 years ago, 40,000 of people post-stroke. Right now, 90%. So it's skyrocketing, and we observe 20-year-old people in the hospitals. We have the MDD certification. We see right now that the number of the adoption is speeding up. However, this is a new device on the market. And basically, we are open for any discussion, not only about the therapy and therapeutic use, but also for we are open for clinical studies, clinical trials. We are working right now with more than 40 different universities. Thank you very much.
Thank you very much. Thank you, Bernard. Yes, I'm sure that we will have interesting conversations about the dual-use technologies. There is a budget for this kind of innovations and growing, so I'm sure that we can tap into that. We're staying with the brain. Luca Gherardini, Sano Center for Computational Medicine. This topic will be very related to what Bernard showed. Luca holds Masters of Science in Computer Science and is completing PhD in medicine. He has a strong background in artificial intelligence applied to healthcare data in collaboration with various companies across Europe and different universities. What do you need to fight dementia, Luca? That's your presentation. The floor is yours.
Yes. Hello, everyone. My name is Luca Gherardini. And together with Rosemary Blanco, we are here to answer a simple yet effective question. What do you need to fight dementia? So let's start with some small introductions. So Rosemary and I are two PhD students from the Sano Center for Computational Personalized Medicine here in Kraków. We are both working in strict contact with artificial intelligence applied to medical data, which presents a very unique set of challenges and opportunities. And we matured a long streak of projects and collaborations with industries and universities during our careers. And now we're here to tackle this specific problem. Our society is aging. Speakers before me today already underlined that very well. In particular, dementia is bound to increase very steeply in the next years due to this phenomenon. And this requires for a change in the paradigm used for tackling this problem. So, a small description of dementia. Dementia is a clinical syndrome characterized by a progressive decline in cognitive functions, severe enough to interfere with daily life and independence. The current clinical pathway to diagnose dementia and cognitive impairment is quite tortuous. So there is a pre-dementia stage where a caregiver usually or a person close to the person affected by this problem notices the first symptoms and obtains a referral for a primary care visit. This is usually an interview of the duration of 15 to 30 minutes, which is very subjective. It doesn't have objective tools to help the clinician identify what is actually happening. And if the result of this first assessment is positive, the patient is further assessed to a specialist visit through EEG analysis. And if this is still confirmed to be positive, there is an official diagnosis confirmation through biological biomarker tests. All this process is quite complicated, takes a lot of time, and especially in the first stage, is very prone to misdiagnosis. Just to give a number, 50% of people with Alzheimer's disease is not diagnosed. We want to replace these first two steps that are in this blue box with our approach. One single visit, 10 minutes, objective assessment, and the results on the spot. This solution is called NEED, the Neuromonitoring EEG for early detection of dementia. It is 8 times faster than the current pathway, since it takes 10 minutes rather than 1 hour and 30 minutes. It's non-invasive. It uses low-grade EEG devices, which are easily accessible and usable even by non-trained personnel. is equipped with a proprietary machine learning model that is highly interpretable and can therefore be deployed in a large scale. The pipeline looks like that. We use a proprietary stimulation protocol called Mnemosyne to collect EEG data. And from this data, we can extract useful brain biomarkers related to cognitive impairment, which essentially represent brain activity during a passive task. So the user, the patient, doesn't have to do an active action during this test, which further enhances and helps with the compliance and effectiveness of this assessment. Then we use this proprietary classification algorithm called Cactus to provide a report which provides a detailed explanation of why the diagnosis was performed as such, an explanation, and highlights the brain patterns that are typical to of dementia. This pipeline is quite unique because it can operate under very noisy constraints, conditions, which are very typical of healthcare data. And since it's very quick and uses a very accessible technology, we can deploy it in a large scale. We have a very particular advantage because this tool sits in a very unique niche. So our competitors in general tend to rely on two kinds of solutions. Either they provide a very quick and accessible test, which though lacks the transparency and explainability that we want to achieve. So they rely on these black box models that are very difficult to integrate in the current healthcare pathway. In particular, they're difficult to be understood and accepted by the clinician. And on the other side, there are other solutions that are providing detailed and interpretable output, but require very expensive hardware. In general, for a clinical grade EEG device, we're talking about 40,000 euros, while for a low grade device, we are, I think I have a slide. No, I don't have a slide here. We're talking about, yes, it's here. We're talking about $500. So much cheaper than what is usually used. The market opportunities are very interesting because, as we said, society is aging, so people above 60 are rapidly increasing, especially in the following years. There are currently 1 billion people older than 60 worldwide. In Poland, this number is 100 million, and in Poland, this gets to 1.5 million people. So in our vision, we want to grant a system that enables all these people to have a screening test every year, as it happens for other diseases, that is able to improve the detection of this disease and optimize the time to first diagnosis and a therapeutic effect. We have a go-to-market strategy that is very long, but is also very ambitious. We want to have collaboration with local and international entities to validate this tool, obtain data, and make the tool compatible with each specific protocol. We want to go for patent applications to defend our solution. We want to ensure highest quality of standards for this technology, both from the medical and the technological point of view, and start pilot projects with this, using these collaborations. We go also to expand by enrolling skills that are currently missing in our team and start commercialization first from private healthcare and then obtaining a certification to move to the public sector in the future. And then Europe and then the world, I guess. So we are looking right now for small and medium-sized private clinics, retirement houses, or individual clinicians that want to take an active stance against dementia and help us achieve this vision. We want to collaborate with EEG manufacturers because we have a prototype of a device, but we need expertise to make this ready for real implementation. We are interested to collaborate with other researchers that are willing to collaborate with us to validate this approach scientifically. And of course, we're open to investors that are willing to put their faith in us. So feel free to reach out. These are our LinkedIn profiles, and I'm also here for the rest of the day. So let's chat, and please ask me your question later if you want to. Thank you.
Thank you very much. So this is Luca. Rosemary is sitting in the audience. Rosemary, can you wave so everybody knows that you're there? Yeah. I was actually fortunate to wear the band for a day at work, which everybody was asking me what I was doing because it looks very interesting. It's a small device, you place it on your forehead and then it records your brain waves. And I was very curious what the data indicated, and Rosemary looked at me and said, it's interesting. So I don't... Anyway, I recommend talking to Rosemary and Luca. They are very ambitious and my fingers are crossed. They're going also for lots of different opportunities to secure money for development of their idea. Okay, right now, the next presenter, Margarita Hallenberg, is innovator, inventor, investor, and interdisciplinary scientist. She concentrates on ventures building in med tech. Title of the presentation, Bio-woven, Bioactive, Biodegradable Textile Material. The floor is yours, Margarita.
Hello. So, we talk about spirit, and now we'll talk about body, human body, because health spirit in the health body. It is well-known idea. So, good morning, everybody, ladies and gentlemen, dear guests. My name is Margarita, as you know. I had sepsis. I was very lucky because I survived. My determination to find a way to protection people in hospitals against sepsis is very, very, very high. Because my colleague next to the bed, unfortunately, died. So my experience is very, very difficult. So I will talk to you about our invention. I represent BioValley Research, and we have a consortium with Łódź University of Technology. And we developed together idea of Bio-woven. It is idea, a new material which is self-sterilizing and which is biodegradable. We presented this idea to the audience, international audience. So we gain a lot of medals: gold medal, silver medal, special awards. Also, this material and this project has an award as a Master of Sustainability. So it is very interesting. And our very huge, we are very proud of one award. It is award as a green biotechnology startup best on the world. And now up to date, we are on the top of 16th projects on the world from 2 million biotech green startups. So we are from Poland. It is very, very important. Yeah. What is the problem? The problem is in hospitals, especially. The problem is the cycle infection and cycle pollution. because in hospitals we use generally reusable textiles. And it is obvious that those textiles during washing make us a big problem, especially with the health, because make us suffer because of infection, hospital infection, and it is also a big problem because of environmental pollution by wastewater. So, what is the solution of this problem? What we want to do? We want to eliminate infections cycle in hospitals, and we want to eliminate pollution cycles from environment. And we want to do by special kind of material. It is the third revolution in the hospitals. Yeah, the first revolution was to implement the textiles into hospitals. It was 2 centuries ago. The last centuries, it was a century in hospital of single-use textiles. It is also a huge problem with environment. And our offer is to biodegradable textile, self-sterilizing. What does it mean? Stop sepsis and infections in the hospitals. What we did, we have a technology for raw material production. We construct the laboratory station, and we produced minimum product value. That means a small amount of material, and we have also some results. For example, here you can find photos of our material. Here you can find the gaps, the traps of biopolymer. You can compare with photos on the top. Here is a pure fibers. Yeah, these fibers are made from cellulose, and these traps is made from biopolymer. So this material really exists. Here you can find some lab test results. It is very interesting because this material is it's according to the standards, ISO standards here for viruses. Yep. Here for bacteria. It is different tests done by different laboratories. So it is evidence that this material really protect people against infections. For example, here, durability of activity is 6 months, but we know that it is even 10 years. Yeah, here you can find the next results. It is, for example, Candida, for Aspergillus niger. Yeah, it is fungi. Yeah, gram-positive, gram-negative bacteria. And this is very interesting. Yeah, because this material has activity against the human influenza. What is the market? It is very interesting because what we want to do with market, we want to produce all materials or textiles needed in operational rooms and also in the world. So we can produce from this material beddings, clothings, sheets, bed sheets, uniforms, drapes, everywhere, what we want. Yeah, it is very nice and in using. So, what will be the result for the hospital and for the people? We want to protect even 3 million human lives it is 10% of patients in hospital. Even 60% infections comes from textiles. It is each year. Each year, 3 million people die because of sepsis and hospital infections. Yeah, it's more than Warsaw, only in Europe. It is very important, but also we have to talk about money. Each cost of treatment infection in each hospital in Europe is 12,000 euro per person. If we multiply it by 3 million people, yeah, it's it's milliards, billions of euros. It is very important, of course, it's cost of our biotextiles. Even 1,000 euro per one medical staff, one person of medical staff, our material, our textile is cheaper. Of course, we have the environment additional effects. Millions, billion, even water, a liter of water we can save. Thank you very much.
Thank you. Thank you, Margarita. Thank you very much. And Andrzej Haremski will be presenting now. Last not least, I'm going to introduce Andrzej a little bit. So you studied medicine, so you are a doctor by training, but you pursued different type of career. Andrzej has significant experience in international business collaboration. Having lived and worked in several countries, he utilizes his experience to focus individual and societal needs and behaviors. A strong believer in the potential of AI development. Yeah. Andrzej is active commentator on the subject in the media, TOG FM, Polsat, Rzeczpospolita. You find him. He is quite vocal about what he thinks about AI. Title of the presentation, Palsy View, Early Detection of Cerebral Palsy in Infants.
Thank you. Margarita said something about her experience. I had an experience. I was very, very small. Actually, my age was 0 because I was born dead. By the way, I survived. I am alive, quite sporty guy at my 60s. Anyway, this is presentation. This is not pitch deck. This is presentation about problem and solution. So, how much children are born with cerebral palsy? Just anyone knows? Some guess? Occurrence, please, guys. Where's the quick clicker? 1 in 450. This is one of the most frequent neurological disorder on Earth. No one knew it. Okay, look at numbers. Look at numbers. This is a global amount of every year's occurrence of children with CP. Every one of you saw some children with CP, on wheelchairs, with different stages of development of this illness. I will not talk much about development of illness because this is very, very medical, this difficult stuff. I will concentrate on some other issues. Social problem. What is the social problem? Actually, everything is written here. And this is a very, very small amount of what I could tell you about real problem, especially mother's problem. Look at one thing, it's not brought here. Do you know that in families where a child has a CP, cerebral palsy, in this, a man a man goes out of family. 60% of mothers are left alone with those children. This is the problem. I don't mention about education. Sorry guys. It's too close. Right. About problems with education, family break. Oh yeah, it's family breakouts. Inability to function, reduction. Mothers don't work usually. They beg. They are beggars. They are professional beggars for money, for children, for rehabilitation. How it looks from economic point of view, it's on a screen actually. We have developed systemic solutions for such illnesses, like some problems like homocystinuria, glutaric acidosis, and those two to another one. Look at the occurrence. 1 in 290,000. One case in almost 300,000. Savings. How much does it cost if it's not early diagnosed? How much it costs if it's diagnosed early? Savings. These are some numbers. These numbers are boring actually, but extremely important. What we want to do? We want every child on Earth, I mean it, every child on Earth to be diagnosed, screened, diagnosed in a proper way, in a proper moment, because the best moment to diagnose it is at birth, which doesn't happen in 50%. It doesn't happen in 50% of cases. Just be aware. And we want to introduce our solution when a child is 4-5 months old. In this moment, every child having CP presents certain movements, every child. So we can detect them, measure them, and do something about this later. It's easy. Mother takes a phone, registers short film, sends to our system, and gets feedback. May we have a film, please, right now? Możemy mieć film? Right. From our point of view, the most important are those things. This is recording due to our computer, our AI. What we do, we'll analyze it from medical point of view. This is how it looks. Every point is measured in time. The same here. How it works generally. Recording, it should be done at home by mother. It's the best way to record children because they are quiet. Don't cry. They are in home. Data goes to our system, our algorithms with our medical device. Medical device in this case are our algorithms. Detects if children has cerebral palsy, doesn't have cerebral palsy, or ask to repeat measurements, recording another time. Report goes further to the whole network where we can apply early intervention. It's extremely important to start when a young brain is elastic, neuroelasticity. It lasts till a child is some 1 year and a half old. Later it finishes. Advantages: user-friendly, easy, very cost-effective. Benefits: it's written. Just by the way, only in Poland, which is not the biggest country in the world, we can save into our system 70 million euro a year only on this small diagnosis. 70 million euro a year only on this procedure. What we want to achieve here, we want to ask anyone, people of goodwill and wanting to earn also, but about this we'll talk later, to join us. These are our needs. If someone recognizes this field, please catch me outside. Actually, I am easy to spot because I'm the only guy with cap on head, so you'll find me in the crowd. These are us, boring stuff. And please take your phones and scan this code, please. Done? If it's done, I am done too. Thank you for this.
Thank you, Andrzej. So yes, this is our break. Thank you all the speakers, and thank you for your patience. This session was very long, but I think that it was really impressive to see all the solutions. Thank you once more.